Good morning, everyone, and welcome to our very first Meet an Expert session for 2024. And I'm really delighted to have a very special guest today, the wonderful Dr. Mark Melin, who's tuning in from Minnesota in the US in the middle of a snowstorm. And we really appreciate him making his time available on a Sunday evening. He's a distinguished vascular surgeon and wound healing expert, and also has extensive interests in human physiology in space and its translation to terrestrial care. And he has a really unique perspective on things like the lymphatic system and the glycocalyx. So I think you'll be hearing some things today that you probably won't hear elsewhere in your medical curriculum. So it makes it an especially valuable session for you to be part of. So the floor is yours. Thank you.
That's perfect. Thank you, Rowena. Glad you all are joining me. I appreciate it. If you look over my shoulder, I'm in Rochester, Minnesota, so just south of Minneapolis, St. Paul, and we're in our first major winter storm of the year. It's been a very unusual, I think it's been almost the warmest winter on record. So I always, when I start this slide deck, I always want to include Heather, who's now married to Barnhart, but Heather Hettrick and I have done a lot of work together. In fact, we had done a space flight analog testing about a year and a half ago. And so one of the things we're going to be talking about is if you're going to do any work in aerospace medicine, aerospace physiology, you're always going to start with ground-based analogs. And whether that's animal-based or whether that's human-based, one of the studies we did was a head down tilt 6 degrees. So this is one of the very validated forms of spaceflight analogs. And the reason you do it, and we're going to talk about this, is you get fluid shifts into the head and neck that simulate something that's about 40 to 70% of astronauts in long duration space missions up on International Space Station will get something called SANS, or SANS. It stands for Space Flight Associated Neuroocular Syndrome. And the reason I got into understanding adaptive physiology is because we deal with a lot of fluid shifts in our patients in the wound clinic. And when those fluid shifts, because we live in a 1G or 1 gravity environment, it really delays wound healing. And because when you flood the leg with fluids, which a lot of our patients with congestive heart failure, pulmonary hypertension, renal dysfunction, on dialysis, hepatic dysfunction, peripheral arterial disease, diabetes, all of these cause lower extremity fluid sequestration. Well, the common link to that actually is lymphatic dysfunction. So not all these people have lymphedema, because sometimes it's reversible. Like if we stop, there's certain medications like Norvasc, amlodipine, some calcium channel blockers that actually are very angioedema causing. So they'll cause the small blood vessels to separate. They flood into the legs and you get a lot of edema. In fact, I had a farmer from Iowa who had been put on this medication maybe a year ago, and he came in and I thought he looked like he was in florid right-sided heart failure. And he was on amlodipine. We stopped it. 6 weeks later, he had shed 37 pounds of water. And that was just all medication related. So that was obviously reversible because his lymphatics worked. But these are some of the important things. And I'm going to pop down a couple slides and start at this one right here. So again, when you're in low Earth orbit, you have this dramatic shift of 2 liters of fluid. So about a liter from each leg up to your head and neck. And this, for some astronauts, they adapt to this over the course of time. But for some astronauts, this really never gets much better. And they feel like they have, it can change their taste. It can make it more difficult to taste food, which can take away your appetite. It can change your optic nerve. It can change your retina. You can get, and then you start to change vision. So almost all astronauts will actually bring up an extra pair of glasses just because of this. But this fluid change also has been demonstrated to end up changing intracerebral or brain health that we're going to end up talking about. So here's the a commercial crew that went up on, and these were all private citizens. So Jared Isaacman, and then Haley Arsenault is actually a physician assistant in Nashville at St. Jude's Hospital. She had multiple. She was the youngest person in space. She was also the first one to go up after having had a cancer and a prosthetic put in her leg. She actually had to have her femur removed, and so she's got a prosthetic. And I would love to talk to her because it's very interesting her reaction when she got into space. The general comment by the four of them, who again, not commercial astronauts at all, they went through a very relatively short period of training. And the comment was, it's just this pooling in your head, like when you hang upside down in your bed. Well, that would be that space flight analog or head down tilt component. But you have to kind of find a way to just ignore it and work through it. About a day later, it kind of balances out and you don't notice as much. And you can see from the cover of the Time magazine to what they look like after about 48 hours in space. All of their faces, the foreheads are thicker, and they all have a little bit more periocular edema. And they've actually done really good validated studies on crew in space to look at forehead thickness, to look at jugular vein distension. Everybody's jugular veins gets bigger in space because they have a hard time draining. So as you're going around the Earth, you're not actually in microgravity. You're still experiencing 90% of the Earth's gravitational field. What's happening is you're falling around the Earth because to get orbital velocity, you end up going 17,500 miles an hour. So it's like constantly falling down an elevator shaft. That's what contributes to this dramatic fluid shift. Genetically, some people can tolerate this much, much better than others. And Scott Smith and Sarah Zaward and Grace Douglas at NASA have really done a lot of work on this. Scott and Sarah came up with a whole theory, I think about 12 years ago, that's really become a significant component of why astronauts get this. But then you bring in the ethical stuff about testing astronauts based on ethics or based on genetics. But here's the model that Sarah and Scott put together. And I think this is a really important model because this is how I look at my patients in the wound clinic. And this is how we should be looking at a lot of our patients in terms of the ability to heal. And specific to space, if you look up at what's going on up in the International Space Station, that's about 250, 270 miles above the surface of the Earth, they live in a carbon dioxide environment that's 10 times normal of what we live on Earth. So it's relative fractions higher, but that can contribute to some degree of vasodilatation. They, of course, get more radiation exposure in space. Their arteries actually get stiffer. This has been proven now in multiple studies. They get a little bit of insulin resistance and they get this fluid shift. So if you combine insulin resistance, arterial stiffness, and all of this, you're basically diffuse inflammation in the body. And they've actually shown this, even astronauts' core body temperatures increase by about 1 degree when they're in space. So they call it inflammaging. And what this does is it actually accelerates your body's aging while you're in space. So astronauts, if you're up for 6 months, and of course, some of the recent astronauts, I think there's been at least 3 or 4 on the US side that have been up at least 12 months. And it really has an impact that takes a little while to recover from. But what's happening at the microvascular level is, this would be about a 10 micron size vessel. So here's a red blood cell, and as they come down, what you're trying to do is consistently have vasodilatation because you need to deliver oxygen, you need to deliver nutrients, and if your blood vessels clamp down, like if you're in vasospasm or chronic diabetes, chronic smoking, it ends up destroying or limiting the amount of oxygen and nutrient delivery to your cells. So what's happening in space is this is where the stiffness comes from because they lose some of the ability to perform nitric oxide. That loss of nitric oxide ends up having an impact on your retina, your optic nerve, and on your brain. You also lose the ability to quench what are called MMPs, or metallomatrix proteinases. And when you can't sequester these things that contribute to inflammation, you end up getting increased collagen turnover and you end up getting more elastin breakdown. So that messes up the elasticity of your arteries. That goes back and also contributes to your arterial stiffness. So there's a lot of things going on in space, and genetics, if you look at the upper right-hand corner, are a huge part of this. because if you have any genetic abnormalities, so we know about homozygous states where you're missing both copies of the gene, heterozygous states where you've got one normal gene, one abnormal gene. But one of the ones that Scott and Sarah identified was that if you can't produce 5-methyl tetrahydrofolate because you can't metabolize vitamin B6 and B12 very well, this is what contributes to a little bit of increase of homocysteine, and that floats right back down to your decreased ability to produce nitric oxide. This is stuff that I suspect you guys are studying in first, second year medical school, but this has real, very high relevance to actually what's going on, not only in the astronauts, but also in our wound clinics. I did a retrospective study of 88 patients in our wound clinic looking at one gene abnormality. Normal walking around patients, normal population, about 20% of people will have a MTHFR abnormality. We found in our wound clinic population, just no bias, or no, just a straight 88 patients, 58% of people had a MTHFR abnormality. So it was almost 3 times higher than normal population, which makes a little bit of sense because there's a reason that those folks are not healing. This just shows it a little bit at a higher level. Again, this would be an endothelial cell. This is about the size, just a little bit, about a half the size of your hair. But when you have all this inflammation going on, what it results in is increased fluid leakage outside of the vessels. So if you have this big fluid shift and now your vessels are leaky like a leaky hose, you can just see how that results in your face expanding, your frontal lobe expanding, and then also the changes within the brain. Now, what's going on at an actual cellular level is if you're changing what's called the shear stress across these arteries, it results, again, this is where it gets down into the real details of why you lose the ability to produce nitric oxide. But it's not just the loss of nitric oxide, it's also the inability to deal with reactive oxygen species. So it's a double whammy. If you can't produce nitric oxide, you can't quench inflammation. The two are intimately linked. And this is then where it gets into the impact on the retina. We know that as the retina starts to swell, and the retina is actually one of the highest metabolic organs in the body. It really needs a lot of oxygen, it needs a lot of nutrients. And when you change the thickness, it can actually have an impact on the entire retinal nerve. So when they do on the station, they do ocular testing. So OCT is ocular, oh my gosh, I'm going to coherence. I'm blanking on the name of it, but they can actually look at the retinas up on space, and they can actually also measure your total retinal nerve thickness. And the nerves actually get thick. A thick nerve is a dysfunctional nerve. And this is actually the retina is basically a direct extension of the brain. So if something's going on in the retina, chances are there's also changes going on in the brain. So some of the things that aren't taught really well in medical school are the concepts of the lymphatics, the G lymphatics, the meningeal lymphatics, and then this concept that we're going to go a little bit more in depth into of the endothelial glycocalyx. So I showed you endothelial cells, but on top of all endothelial cells, so there's about 60,000 miles of blood vessels, arteries, veins, lymphatics in your entire body. Each of that 60,000 miles is lined by a paver. That paver is the endothelial cell. But over that entire length of 60,000 miles is a very complex sugar layer called the glycocalyx. So it's got proteoglycans, glycoproteins, heparan sulfate, chondroitin sulfate, integrins, syndicans. But this sugar layer is also electrically charged. So it's a negative charge. Your red blood cells are also negatively charged. And that's one of the things that makes the efficiency of red blood cells going down into these small blood vessels, that the slight repelling force makes red blood cells move much, much quicker and much more functional in terms of delivering oxygen and nutrients. This is one of my favorite papers of all time. It was published in 2014 by Drs. Mortimer and Dr. Roxon. Dr. Roxon's at Stanford in California. Dr. Mortimer is in London. And this was really the paper that opened my eyes to what's going on with the lymphatic system as well as the glycocalyx. And one of their opening statements was the lymphatic system is fundamentally important to cardiovascular disease, infection, immunity, cancer, and we know for sure now it's absolutely related to obesity. And these are really the four major challenges that you're going to deal with over the course of your career. We also now know that there's a significant lymphatic dysfunction within diabetics. There's a significant lymphatic dysfunction within even critical limb ischemia. So it affects everything I see on a daily basis. I have two children and a daughter-in-law that are in medicine. They're just in various forms of medical school or their residencies right now. And we talk about this often, that what they were taught in the first year, second year medical school was this classic Starling force. The classic Starling force teaches that when your blood flow from the artery, again at the 8 micron level, goes into the veins, it squeezes out like a wine press the fluid. So that interstitial fluid or the oncotic pressure pulls it out. Some keeps it in, but there's supposed to be a balance. The classic teaching is that 80% of that fluid comes back into the vein and only 10 to 20% goes into the lymphatics. And that was from Starling's work in 1896 in Guy's laboratory in London. But here's back to Roxon and Mortimer's paper. We know that teaching is actually now wrong. So in A is the classic teaching where it shows that there is a filtration and then a net absorption back into the vein. And this is what you all were taught in medical school, correct? This classic form. Have you been taught the modified Starling forces, which really started to come out in the late 80s, early 1990s, and certainly by 1997, by the time of the 100th anniversary of Starling's work, it was proven beyond a shadow of a doubt, there really is not net reabsorption. When the fluid comes out, it doesn't go back into the veins. It actually has to get picked up by the lymphatics. And because of 80 to 90% of that fluid going to the lymphatics, that means the lymphatics are incredibly important to body function. So that's what really created this renaissance of lymphatic research, both from the benchtop as well as to the clinical aspects. So here's one of my patients in clinic, and it's amazing how often somebody will look at this leg over on the left-hand side and they'll say there really isn't much swelling there. And then when you kind of put your finger over the tibial margin and it leaves a big dent like this, that's clearly lymphatic dysfunction. Now, is that lymphedema or is that lymphatic function? It depends. You got to take a good history. How long has it been present? Maybe the patient's in the hospital with sepsis, so they're diffusely edematous. If they say, look, I never had swelling like this until I got really sick, it's probably lymphatic dysfunction. If they say, I've had swelling like this for 40 years, you go down and examine their foot, they've got a Stemmer sign, they've got a buffalo hump, then it's going to be lymphedema, in which case you're helping the patient make the diagnosis. So there's an international staging in terms of lymphedema. So for patients that truly have it, stage 0 would be latent or subclinical. The patient tells you, my arm's full. Say a woman that had mastectomy and now has lymphedema of the upper extremity. They may feel this long before we can even detect that there's a dysfunction just based on clinical examination alone. So stage 0 is latent or subclinical, really no objective evidence of swelling, but the patient's telling you something's changed and something's wrong. Stage 1 would be early accumulation of fluid, usually pitting, but it subsides when you elevate the extremity. Stage 2 is swelling is rarely reduced with elevation, pitting still present in early stage. And then this eventually results in progression to fibrosis. So in stage 3, you really get these, what's more like elephantiasis changes. You get thickening of the skin, you get plaque development, you might get nodules. The difference between stage 1 and stage 3 is that as you flood the tissues with all this extra fluid, you lose microcirculatory perfusion. So basically you're getting subclinical ischemic changes to the skin. That's what causes the disordered skin. That's why you get the thickening of the skin, the fibrosis, and these large nodules. So it's a relative ischemia issue that's happening. This again just kind of goes back into this, what is lymphedema versus lymphatic dysfunction? Because if you hear the statement all edema is lymphedema, that's not quite true. You really need to differentiate into lymphatic dysfunction versus lymphedema. So again, the big original date was 1896 for Starling doing his work in London, and that really changed on about the 100th anniversary with C.C. Michael's publication. He gave a beautiful speech in London about going back and honoring Starling, but really saying, you know what, we now know that this is not correct. So here's what the endothelial glycocalyx is, because this is what makes the difference. The presence of the endothelial glycocalyx is what changed the starling from the original to the modified, because this is what, it's like a Gore-Tex layer. This is what prevents the reabsorption of fluid. So it lines all arteries, all veins, all lymphatics. In fact, just I think it was last year, Joe Raffetto, Stanley Roxon, Giacini from Italy, they published the first human specimen, the first proven human glycocalyx within a lymphatic sample. So I use the acronym EPIC. So endothelial cell cytokine production. So it's the nitric oxide, it's the prostaglandins. These are all the things that are very healthy and make blood vessels function. It's that permeability layer that we talked about, Gore-Tex like. It quenches inflammation, and then it also regulates coagulation. So if you think of the glycocalyx as this thick, as it starts to get thinner, then it exposes coagulation factors. That's why you get microthrombi. This is one of the reasons why people in COVID got microthrombi, because based on what we know from Hans Vink in Amsterdam, who did the MYSTIC study, COVID sheds the glycocalyx. The glycocalyx is thinnest in the lungs. Hence, this was one of the first symptoms you see in COVID is you get white out of the lungs, or microvascular hyperpermeability within the lungs. And then it's the thickest in the brain, or as part of the blood-brain barrier. So here's a good picture of an intact glycocalyx. So you can see the scale of it. There's a red blood cell, so we're back into an 8 or a 10 micron blood vessel, about 1/3 the size of your hair, and it looks almost like seaweed attached to the endothelial cells. It's very complex, all sorts of different sugars. So there's that epic mnemonic again, the endothelial cell function, that when the seaweed waves as the blood flow goes across, that's what stimulates the endothelial cells to produce nitric oxide and the cytokines. So you have to have that waving, or what's called micro-oscillatory shear, to stimulate the glycocalyx, that stimulates the inside of the endothelial cells to produce these things. This is the permeability layer we talked about. When it's intact, the fluid is normal regulation. When the glycocalyx is gone or shed, then you get this diffuse microvascular hyperpermeability, and you just weep fluid out. The coagulation barrier we talked about, and the inflammation quenching we talked about. So I think this is a beautiful example of microvascular tree. 80% of your body, 70 to 80% of your body is actually in the small blood vessels. The blood vessels you can feel, like the radial pulse, the posterior tibial pulse, those are very, very large vessels. The macrovasculature, main aorta, 2 centimeters, typically if it's non-aneurysmal, but all oxygen delivery, nutrient delivery is within these 8 micron vessels. And if that's 80% of your body, it's a really critical functioning aspect. We hit on that slide a little bit again. Here's some work from Enno Ebong's lab at Northeastern University in Boston. I was very privileged to be able to do a study with her on looking at carotid glycocalyx within a mouse and restoration using something called diosmin hesperidin. But again, this just shows it's made up of heparin sulfate. Albumin's a big component of this, chondroitin sulfate, hyaluronic acid. And think of it as the lawn on in your front yard. So that lower D level that says glycocalyx, so this is the GCX. Think of this as the dirt, and this is the lawn. And obviously, if you cut your lawn too short, the grass will all die, and then you expose it to the sun, and then all the endothelial cells die because the lawn becomes so hardened and clay-like. So keeping a good thick component to the glycocalyx is incredibly important. Here's the things that damage the glycocalyx: smoking, high blood pressure, high cholesterol, hyperglycemia. So diabetics are constantly shedding their glycocalyx, and the body's trying to match it by rebuilding it up. Sepsis causes this, trauma, radiation. So those, some of the common things we know that cause people to swell, it's because of loss of the glycocalyx within the blood-brain barrier, and it looks a little bit like dryer lint. Here's without the glycocalyx, here's with the glycocalyx, and this is that complex blood sugar. And again, this is within the blood-brain barrier component. This is just to show again, as the fluid goes across across the endothelial cell, it's all causing leverage or levering arms to end up acting inside of the blood vessel. So this is all called mechanical transduction. It's an engineering word, but again, as the fluid goes across like this, it moves these lever arms that energy is transferred into the cell, and that's what's causing production of these cytokines. Now, one other important genetic abnormality to bring up is something called piezo-1 and piezo-2 channels. And this is actually one of the most common causes of varicose veins, is having abnormalities of the piezo channels. And it's been nicknamed the feel of the force gene. It's actually incredibly important, not only in vein development, but also lymphatic development. So a baby that has a fetus that has no normal piezo channels actually will develops hydrops fetalis, and almost always will die within a couple of days of being born because the lymphatic system systemically is non-functional. So keep an eye out on piezo-1 and piezo-2 channels, because I think this is going to become an important part of genetic evaluation of disorders in patients, especially in our wound clinic patients that have venous leg ulcers and lymphatic dysfunction. But I think the other really important thing to understand is if these channels are initiated and function by mechanical force or weight, what is happening to astronauts that get into space that have abnormalities in piezo-1 and piezo-2 channels? Because once you get into space, you get into weightlessness. And if you don't have a mechanical force pushing on your tissues to activate these channels to make them functional, then what does that do to an astronaut? And nobody's studied that yet, but piezo-1 and piezo-2 channels have significant impact throughout all systems. So it impacts glial cell function, myocardial inflammation, vascular endothelial inflammation, pulmonary dysfunction. It really is in every single tissue throughout our body. So I think there's a lot of work here to do on piezo-1 and piezo-2 channels and weightlessness. We hit on that. We've talked already about the shedding. Again, here's a normal glycocalyx. You get shedding. Let's just say you got sepsis. Your glycocalyx is gone. It gets thin. Or in chronic pathological conditions like diabetes, it's just constantly you're thinning the glycocalyx, and your body's always trying to restore to maintain homeostasis. Now, one of the interesting things about high intensity exercise is that it builds or thickens your glycocalyx. So this is part of the reason why when you exercise, you get conditioned, you can have better functionality, you have improved nitric oxide function, you can get good vasodilatation, good oxygen, good nutrient delivery. This is what's going on. And this study, I think this was performed in 2019, showed that when you're doing high intensity workouts, you improve the functionality of your glycocalyx. So this is where we should be telling our patients with diabetes, that are obese, with limb ischemia, maybe claudication, exercising does make a difference in terms of microvascular health. And if you look at what the astronauts are doing on station, they're having to exercise 2 to 2.5 hours, 5 to 6 days a week to maintain cardiovascular health, to maintain bone health, to maintain their overall aerobic capacity. And it's a really, if you thought that having to give up 2 to 2.5 hours a day to exercise is a big deal for astronauts, because there's so many research experiments they have to do. And Rowena will tell you about, she's had plenty of understanding and knowledge of this. You know, you'd love to be able to do 2 hours worth more of experiments on a daily basis, but you have to commit this to exercising. Otherwise, your body in weightlessness will literally start to deteriorate. So you have to do this if you're going to stay up on station. And these are incredibly highly engineered exercise devices for resistance. And they've got a treadmill that you're basically belted down on. I mean, just the engineering that went into creating these devices is incredible. This is just to give you a sense of lymphatics within the skin. This is all lymphatics within the skin of a mouse. Anything that is this dense in the body tells you that there's a critical importance to how this works. And so look at the density there. And this is actually one of my patients. I got done debriding a big venous leg ulcer on the left leg. And when you look at the blown up image here, each one of the ends of here is a dilated lymphatic vessel within the skin. So I'm going to take it back one more time and look at the density there. And that's basically where you're seeing in lymphatic dysfunction. So this is phlebolymphodema or venous leg ulcer with lymphatic dysfunction. And all of these are just dilated, collecting within the skin. And you can see this big nodule right here. This is stage 3 lymphedema. So and the reason you get these big nodules is because when you can't deliver oxygen and nutrients, the skin gets disordered and just grows abnormally. And that's why you get these big nodules. So again, here's artery going into a vein, all the fluid leaks out, the lymph vessels are picking up 90+% of that fluid, and they're then carrying it back through the body. So here's in the skin, the lymphatic collecting system. It's almost like the leaves of the palm trees. It carries it down, it carries it back along the main vessels. It's also the immune sensing component of your body, because as you collect that fluid and it comes down, it's going to go through the T regulators and the other cells that are within macrophages within the lymph nodes and to get cleared out. This again, this is a lymphangiogram. Again, the density within the lymphatics within the skin, really, really important component. Here's again the glycocalyx within lymphatic vessels. The functional component of the bigger lymphatic vessels is called the lymphangion. A lymphangion is divided from one valve to the other. So this is the lymphangion unit. That would typically be a great a test question about what's a functional segment of a lymphatic. A lot of work has been done looking even at nitric oxide, because within these endothelial cells, so as the fluid goes across this, and obviously this is not blood within the lymphatic vessels, but it's more like hydraulic fluid. But as that fluid goes across, it stimulates the glycocalyx. That's what causes lymphatic endothelial cells to produce nitric oxide. Even within the valves, you see layers or gradients of nitric oxide production. And I've always looked at, if you look at this is actually, I think this was Apollo 12. And if you look at the flume coming off the back and you look at where this develops, it's all fluid mechanics, because this matches similarly on a lymphangion. So the fluid mechanics within development of lymphatics help set up where those lymphatic valves ultimately develop. And if you really get into rocket exhaust plume phenology, this is one of the books I own. It's fascinating how these plumes off the back of the rockets develop. And this is actually called a mock diamond. So again, it almost looks like a lymphangion there, but mechanics and bioengineering of it are phenomenal. So once you collect the fluid within the leg, it gets carried back eventually up into the groin. It goes in the retroperitoneum, comes up the thoracic duct, and it's going to drain into the left subclavian vein. So you can see there's a difference between the two sides of the body. Right leg, left arm, left brain all drain into the subclavian vein. However, on the right system is relatively isolated. Right arm, right upper chest, right brain all drain into the right subclavian vein. The reason the difference is, and if you see that it makes a little hook up into the subclavian vein, same here, it makes a little hook up. If you connected directly on the underside, you would drain blood back into the lymphatic system. So, you know, the teleologic reason for the design of this is to prevent back bleeding of blood into the thoracic duct on both sides. That's why you see this little. And if you get into reconstruction, I'm not a lymphatic reconstructionist. We work with plastic surgeons to do all that. But this, you always want to make sure that you have this kind of reanastomosis or a valve closed so you don't get bleeding back into a lymphatic system, because that'll shut down your lymphatic system. The reason it's isolated is because embryologically at about week 6 or 7, when the main aorta develops, there's actually 2 main thoracic ducts. But as the aorta develop, it crosses and isolates the right system to its own. And that's why you end up with both legs and the left arm going up into the left subclavian. I'm going to go to the ventral medial bundle along the medial aspect of the leg. This is the main outflow of the legs. And if you think about what's going on with astronauts, and nobody's proven this yet, but this is probably where a lot of this fluid shift is coming in, because if you get you get this squeeze of the fluid up, it's going to be coming up the ventral medial bundle. One of my reasons for suspicion is that on the cosmonite side, they'll wear 40 milligram or 40 millimeter of mercury. They're called bracelet cuffs. So they'll put these cuffs at the top of their thighs. So let's just pretend we're up at the top of the thigh here. they'll wear a thigh across here up to 40 millimeters of mercury for 8 hours a day. And when you do that, you actually decrease the swelling in the head and neck, you decrease intraocular pressure. And I think it's because you're sequestering not just the venous blood, but you're sequestering all the lymphatic return down here. And as you do that, you do a drawdown of the fluid. So there's a lot of great work to be able to be done, improving exactly why those bracelet cuffs work, but it's a great form of mitigation for that fluid shift. One of the other things, and this was from Steve Dean's paper that was at the Ohio State, when people do when orthopedic surgeons do total knee arthroplasties, they actually put a tourniquet on the leg at 250 millimeters of mercury for about 60 to 90 minutes while they're doing the knee arthroplasty. And it's interesting, in Steve's data, he noted that 58%, I think this is 58%, correct? 57% of patients ended up with chronic lymphedema after total knee arthroplasty. Now, you should sit back and think, wow, you mean if I get a knee surgery, I have a 57% that I'll have lifelong lymphedema in that leg? We think it's because of the tourniquet that's used, because if you look at data where the surgeons don't use the tourniquet, the lymphedema development is much, much lower. In fact, in a Chinese study where they did bilateral total knee arthroplasty at the same time, one leg got a tourniquet, one leg didn't. All the outcomes in the no tourniquet side were much, much better than with the tourniquet. So I think ultimately getting to no tourniquet in the in knee arthroplasties actually will make long-term lymphatic function much, much better. This is actually a paper from the ALERT system. So the Australian Lymphatic Education and Research ALERT, Dr. Swami, he published this in 2018. If you don't have this paper, I would grab this paper and read through it. He developed and discusses the lymphosome component and how the body, each segment of the body has a different lymphatic draining system. And so again, skin level, these are the collector systems that are those. And see, these are very spaced out, but actually what I had shown you before, where they're very dense, is more true to anatomy. So those will collect down, and then this is the lymphangion level. Anything that's got a valve is at the lymphangion level. And as those contract, they'll pull the fluid even down or further down into the main collectors. Now, if you look at the deep tissues versus the subcutaneous tissues, unlike veins, there are no perforators. So basically, superficial tissue keeps it superficial, the deep tissue, muscle, etc., keeps it deep. There really isn't a collection between those two. That's why if you see certified lymphedema therapists that do manual lymphatic drainage, they can massage this tissue in a very specific form and really do a nice job of getting the lymphatic fluid out. Now on the left, this is the Shiba suit that is a negative pressure. So the astronaut puts their body into this. It basically sucks down on the body. And when it sucks down, it draws fluid out. So it can lower intraocular pressure. It can draw down the swelling in the head and neck. And the fluid then, again, it's sequestering fluid down here. So essentially, one of the methods that certified lymphedema therapists do to get rid of localized swelling is they'll put a suction cup on, and this creates negative pressure here. When you do that, what you're doing is you're opening up the gaps between the endothelial cells of the lymphatic capillary. When you open up those gaps, you allow fluid to pull in. And because the lymphatic system is naturally a negative pressure, it's actually subatmospheric in pressure, it'll just suck everything in like sucking on a straw. And that's how you get the fluid out of the skin. So this is, again, up on the space station. And Alan Hargens, who's out at San Diego, has even used a model of this by having, you could actually walk on a treadmill. So you're almost laying flat walking on a treadmill to help stimulate the same thing. But this has been incredibly effective in terms of drawing down fluid up in when you're in weightlessness up on the space station. It has yet to be shown exactly what is going on in terms of lymphatic impact. There's clearly an impact on venous, but if you're impacting venous, almost based on physiology and the two systems being so intercorrelated, the supposition is that you're also impacting the lymphatic system. This goes back again. Dr. Alan Hargens had done a lot of work on this. He spent time on Africa. He and his team are some of the first people to figure out why giraffe legs don't swell. And it's because the fascia is so tight around the leg. So much like when you do short stretch wraps or good compression socks, it just prevents the swelling. Now, if you look at a bat, bats hang upside down 18 hours a day, but they never get swelling in their head. So the reason that happens is because their lymphangion contractility here is very strong. So as they hang upside down, they're able to push the fluid up much, much better than we are. If we hung upside down for 18 hours, our heads would be really swollen. Our lymphangion contractility in our legs is the strength of our bodies because we're used to standing up for 18 hours a day. And so it's just teleologically, if you just look at where the animal lives in the environment, then that'll give you some sense of how their lymphatics are functioning. This paper came out of the University of Minnesota, or University of Missouri, Michigan, I'm sorry, Joshua Ong, Andrew Lee, and then Heather Moss, and both these folks are associated with NASA. I just thought this was a fabulous picture to help explain again this spaceflight analog component. So here's the International Space Station falling around the Earth at 17,500 miles an hour. And so this creates the microgravity environment that results in the fluid shift from the head and legs up towards the head and neck. You can get the similar type of effect when you lay down. Even just laying supine for a prolonged period of time is a spaceflight analog. If you want to accelerate fluid shifts, then you just have them lie down at 6-degree head down. You can do steeper, like 11, 12 degrees. It's just that patients or subjects typically don't tolerate laying at a steeper angle for longer periods of time to cause the shift. That's why the kind of the compromise value that still gets good science done is a 6-degree head down model. We got about 5 more minutes here, and then we're going to open it up for questions. So I wanted to run back to one of Dr. Hargan's studies that he did way back in 1991. Really, really fascinating study. So 6-degree head down person, they made a little incision in the neck and actually inserted manometers underneath the skin to look at actual tissue pressures. And then they did the same thing actually just inside the lip or in the gingiva. And one of the things they were looking at doing was trying to validate and quantify. So if you're going to go into research, these are 2 incredibly important words. You want to be able to validate, first of all, you want to be able to quantify the changes. So that means you have to have really good techniques and precise tools to measure whatever research you're doing. And then you want to be able to validate that. So once you've quantified the changes, you want to be able to validate it. Is it repeatable? Do I have the right, am I testing and doing the right thing? So this work here is incredibly complex that Dr. Hargens and his team put together to help be some of the first people to demonstrate what was going on at a tissue level in these significant fluid shifts. And one of the important comments that they made in this was net fluid flux across the capillary wall can be determined using the Starley and Landis. But we know that that is no longer true. In fact, it's interesting because this paper was published in 91 and it was just 6 years later that C.C. Michael published his paper showing that the glycocalyx basically needs to modify the standard Starling. Presumably, the lymphatic system is near or at capacity during head down tilt exposure. And because it's at capacity, that's the reason you get the swelling. The lymphangions just can't keep up with it. Now think back to the bat. If you tipped a bat at 6 degrees head down, they could easily compensate for it because their lymphangions are more dense and contract better. Humans just are meant to be sitting up all the time and don't have the ability to contract like that. Now this paper, 1996, then 7 years later, Scott Smith, you'll see, is one of the co-authors. He's one of the folks with Sarah's Ward who came up with that genetic differentiation for why SANS occurs. Headward shift of body fluid estimated to be 1 liter from each leg within 6 to 10 hours of reaching orbit. Plasma volume and extracellular fluid volume decrease. So why is that? That's because the fluid is leaking out of the vessels up into the head and neck, yet your legs get smaller. Increased permeability of capillary membranes may be the most important mechanism causing spaceflight-induced plasma volume reduction. So if we go back to permeability, what results in permeability? Well, it's shedding of your glycocalyx. So the thought is, and this has yet to be proven, is that is there a change in the glycocalyx over top of veins in space that results in this permeability contraction? So I think that's a good point to end, Rowena. And hopefully I've stimulated a couple of you to ultimately do some great research and figure out these questions, because as more and more humans start to fly in commercial space flight, and these are people typically that aren't going to train, the typical astronaut trains 2 to 3 to 4 to 5 years before they ever get into space. And it's really intense training. They're like Olympic athletes. Yet if you take somebody just normal like me, and I spend 3 months training to go into space, I'm probably going to have more side effects, and it's going to take me longer duration to recover. And therefore, if I'm in space and I'm feeling lousy, I'm going to be less productive in terms of getting work done. So I think there's a lot of things to do to figure out how can we mitigate these fluid shifts? How can we maximize that without trying to create artificial gravity? Because trying to create artificial gravity and weightlessness is really difficult. If you start to look at the biophysics and the bioengineering of that, you need massive wheels. I mean, it's these wheels have to be huge, turning to be able to start to create any form of even partial gravity restoration and weightlessness. So there's got to be other things that can be much, much more effective in the end, that improve endothelial cell health and make lymphatics work better in space. Rowena, with that, let's see if we got any questions here in the last 10 minutes. And it was really a pleasure being able to spend time with you guys today. And it's a beautiful Monday for you while we're looking at finishing off a snowstorm here in Minnesota.
Thank you very much for such an amazing talk, and so many interesting concepts, and I think really valuable to be able to introduce that information about the reinterpretation of Starling's original research. And it's a really great indication that nothing stands still in medicine and science, and that things are never black and white, and that we're always learning. So thank you again for a really wonderful talk. And opening up for questions. Does anyone have a question you'd like to ask? Either unmute and ask, or pop your question in the chat.
Rowena, and I see there's one question up here in the chat. It says, that's from, please excuse, just somebody was taken off. No worries at all.
I've got a question. So I was interested in learning about the revised Starling forces. I was wondering if there was anything else that was maybe informed by aerospace medicine that you found challenged our classical understanding of human physiology. Any other examples?
You mean that's been in published data so far?
Either that you've seen yourself, or that you've seen published.
Well, I tell you what, how about if I answer it in this fashion? Let me go back to screen share, and I'm going to fast forward you to one slide here, to a little work that I got this was my entryway into doing a little bit of work in so this study right here is one that I got involved in, because there was an event that happened in space, a DVT. It involved the jugular vein. And let me give you a hint. If you get privileged enough to ever get to work with anybody on NASA, there have been so few astronauts that have flown. Never talk about whether it's a male or female, and never, if you happen to know the name of the astronaut that was infected, never call him by name, because you're breaking all the HIPAA, right? The health information, and you're compromising that particular crew member. So if you ever get to work and you find out that astronaut A had problem X, you never talk about, you just say that crew member. So this particular crew member had a jugular vein thrombosis. It was actually published in the New England Journal of Medicine in January 2nd, 2020. Really interesting thing. So blood clot, they were just doing routine ultrasounds of the neck, because again, the jugular veins get really big, and sometimes they're completely stasis. There's no blood flow in it. They've even seen reverse blood flow in jugular veins and weightlessness. So just doing routine scans, and all of a sudden, this one crew member had a complete blood clot in the jugular vein. They happened to have up on the space station Lovenox in the medicine cabinet. So started right away on Lovenox. They confirmed the diagnosis, started on Lovenox or enoxaparin once daily. You can see the dosing right here. They actually then delivered to the space station on the next resupply mission 43 days later, apixaban, so an oral anticoagulant, and then continued to monitor. And then they made they didn't want to put that crew member and rush that crew member back to Earth, because that actually, the crew member was totally asymptomatic in space with this blood clot. No strokes, nothing else, no pulmonary embolus, was otherwise perfectly fine. So, they're consulting with people across the United States. Steve Mull, I think, was the big one over in North Carolina. He was helping to do this. Then they made the decision, we're going to bring this particular person out, bring him back down. This person came down under the steps in Kazakhstan in a Soyuz capsule, and they stopped the anticoagulation 4 days before deorbit, and then they did a point of care ultrasound. Well, when I heard about this event, my first thought was, what do we know about glycocalyx shedding in space, and how do we know that this could have potentially contributed to why this blood clot occurred? Because we look at the EPIC analogy, right, the coagulation part. So I just simply asked the question. I started making some phone calls. I was very fortunate to be able to get ultimately talking to Scott Smith and Sarah Zwart, and made a proposal. And they said, well, I tell you what, why don't you write it up? So we wrote it up. We ended up having to do some revisions. We made Sarah the principal investigator, and next thing you know, it got accepted. And with that acceptance, we got to get urine and blood samples from astronauts. And so we started looking at what was the components that resulted in that DVT. And what we found, and this is the first published report, that albumin for women that are on combined oral contraceptives significantly decreases. Well, albumin, if you recall, is a significant part of the glycocalyx. It's part of the permeability layer. And if the albumin goes down, it helps to expose coagulation factors. So the other part we found was that there was 3 of 41 male astronauts that had low albumin. So there's probably a genetic susceptibility there, because obviously the male astronauts are not on combined oral contraceptives. The albumin has a direct effect on several components that help stabilize the endothelial glycocalyx, and also changes blood viscosity. So blood viscosity changes can also increase your risk for DVT. And so this was the first report. I think we published this in 2022. A lot more work has to go into this. But I think what this really tells us is that if women are going to spend time in space and spend time on the moon and get to Mars, what is the oral contraceptive you're going to use? Because many women don't, having a period in space can be a challenge. And so if they're going to choose to use a combined oral contraceptive, or to use an oral contraceptive to suppress menses, what's the safest one that doesn't increase a DVT occurrence? Because let's say you're on the moon surface now, well, you're 3 days away, and you may have limitation in terms of treatment. And certainly if you get to Mars, where there's a significant difference, I think we got to start looking at this in terms of what's the genetic susceptibility and what are the right things to do to maintain endothelial cell health. That was a really long answer to your question, but does that kind of help give if somebody's looking to do some research, this is a phenomenal set of data to start building upon, because I think there has to be a lot more work in what happened here and trying to explain it, and starting to look at, I'd love to do work where within the first 24 hours, grabbing samples every single hour, blood and urine, and looking for those components in the blood of the glycocalyx. So heparan sulfate, what's happening with chondroitin sulfate, hyaluronic acid. Some of those ones that shed like leaves dropping off a tree, what are the ones that change right away that result? Because I think during that first 48 hours, I think that's where we're going to find where these significant components are. And if you adapt that, if you match that then to genetic susceptibility, I think we'll start to get some really good answers on who's most susceptible to this. and what are the things we can do to help prevent, because prevention, I think before launch, prevention while you're in space, and then also how do you help rehab astronauts when they get back and help them recover as quick as possible. I just gave you about 10 research projects right there.
Thank you. Appreciate it.
Yeah, it was a great question. Rowena, any other questions?
I can't see any other questions, but I think this particular example does raise the point that there have been far fewer females who've flown in space than men over the history of human spaceflight. And as a result, there's a lot less research on what happens to female physiology in space. So in general, it's a very fruitful area for research, simply because of the relative paucity of research that's been done to date. So I think we'll...
And Rowena, we need a lot of women to go to space, right? I mean, women researchers offer such a phenomenal perspective. They're brilliant, and we need more women in aerospace medicine and more women astronauts. You all can do it.
Yeah, absolutely. I couldn't agree with that more. And there is one question in the chat here. Has your understanding of the revised styling mechanism changed the way you practice medicine day to day?
Yes, absolutely. And one of the studies I didn't get into was our study that we did at Northeastern University, where we showed that a form of micronized purified flavonoid fraction, it actually comes from orange rinds or orange zest. We showed in that carotid model of a mouse injury, that helps to restore the glycocalyx, specifically the hyaluronic acid component, as well as nitric oxide production. So we use micronized purified flavonoid fractions, which in Europe is known as Daphlon. I put a lot of my patients on that. I also put a lot of our patients on B12, B6, and folate, because I know, especially with that MTHFR data we did, I know that a lot of our patients don't make normal nitric oxide. It's hard to heal if you don't have normal nitric oxide. So we put everybody on micronutrients that we see. First consult, I'm putting them on 3 weeks of vitamin A to help with collagen regeneration, B12, B6, folate, high dose vitamin D, which helps with endothelial cell function. We put them on high dose vitamin C, because I think a lot of our patients don't eat well, so they don't get good fruits and vegetables. And if you don't get good fruits and vegetables, you're actually susceptible to scurvy, which in the 1500s, that killed, I think worldwide, like 1 or 2 million sailors just from not having fresh fruits and vegetables. So pay attention to what your patients eat, because I think malnutrition or poor micronutrient deficient is really important. But it's also the same in the extremes of environment. So people in Antarctica, they all take vitamin D supplementation. They are very focused on nutrition in Antarctica because they know they're susceptible, but it's the same in the austere environments like the space station or on the moon. Nutrients are going to be very limited. You can't just go pick an apple or an orange off a tree on the moon. But getting something into space, it's literally $5,000 to $8,000 a pound. So a pound of oranges, it's like $5,000 just to get it into space. And then the oranges aren't going to last very long. So I think the micronutrient components within space travel is going to be critical, and it is very critical in our wound clinics for treating our patients. And
Yes.
all of those nutrients go right back to endothelial cell function throughout the entire body. So ultimately, I'd love to prove that by doing what we're doing with treating lower extremity ulcers, we actually decrease heart attack rates and we decrease stroke risk, because we're improving endothelial cell health function throughout the entire body.
Yeah, it's wonderful to have that additional translational aspect to the work you're doing, which could have an enormous impact on the health system generally. So I think that makes it even more rewarding that you could possibly be helping such a vast number of people. So there's one. Would it be possible for us to have access to these slides?
Oh my gosh, yes. I'll be happy to share these slides with you. Rowena, do you have a copy of this deck? Or otherwise what I can do is put them into let's see, we can get them into a Dropbox or something, but happy to share these slides with you all to learn and look up these resources. Sure.
Yeah, I think we've got the copy from last year, which
Okay.
is currently there. But if anything's changed since then that would be great to have the updated version.
This is basically the same slide deck from last year.
Mm-hmm.
Yep. So feel free to share that with all the students. That's wonderful.
Yep. Okay, perfect. Well, we better leave it there, unfortunately, because there are lots more really fascinating things we could talk about. But if we could all just please say thank you very much to Dr. Melin for coming along today and sharing with us. We're incredibly grateful for your time and for your expertise and for these unique insights that you've been able to share with us. So thank you again.
Oh,
very
my
much.
privilege. Hey, and you as students need to know that Rowena is one of the most respected people in aerospace medicine in the world. So the fact that you guys get to hang out with her is incredible. I'd love to come to Australia and spend a year in her class. I would learn so much. So you guys are all very fortunate to get to spend time with her.
Oh, thank you. That's very kind. Well,
All right.
hopefully you can come down into sometime.
Oh, I would love to. Y'all have a great Monday, okay?
Well, thank you again. Really lovely
All
to
right.
see you.
My privilege. Y'all have a good day. Take care.
Thank you. Bye-bye.
Thank you.
Thanks very much.
Thank you.
Thank you.
Thank you.